you for the invitation, and thank you for giving so many women the opportunity to speak. And of course, I was a little bit late reading my topic, and so there might be a little overlap with Dr. Amato's talk, but also some other aspects of what is a normal pregnancy outcome. And the question, it's a very important question to ask yourself, what is normal? Only if you understand what is normal, you can define abnormal. And that this is not very easy coming to pregnancy. So, and in the next 4 slides, you see 4 publications from the last few years from different registries investigating pregnancy outcomes. This was a US publication. Sonia Hernandez-Diaz is very strong from Harvard, very strong epi-pregnancy researcher, and she used claims data. And you see here, so here are the healthy controls, or not healthy, but at least not coded as MS. Most of them probably healthy. Then women with pre-pregnancy DMT exposure. Here you see the sample sizes. The control group, 1 million, nearly 600 with pre-pregnancy DMTs, and then you have about 1,000 without. And spontaneous abortion rates are 23, 25, 23%. The risk ratios are only between these 2 groups. Then other outcomes, cesarean section, probably with this sample size, I assume the risk ratio would be significant, more cesarean section in the MS patients with DMTs. This was not different between the 2 MS groups. And preterm delivery, 10%, this is what would be normally expected. Little higher here, 15%, 12%. Major malformations, 3, 4, 5%. Nearly similar between the groups. Next registry. These are data I presented for the Nordic Registry and the European Beta Interferon Pregnancy Registry last year at AAN in Philadelphia. But it's mainly data from Scandinavia, and they have the beauty of huge registries where they can link to healthy controls and also probably follow the children. So they had, it's a large number of interferon beta exposed pregnancies and unexposed pregnancies with women with MS. Here you see already much lower spontaneous abortion rates, and that's due to the system. Women in Germany, if you go to the drugstore, you buy the pregnancy test. If it's positive, everybody, including me, runs to the gynecologist and says, I'm pregnant. And you get an ultrasound and you are in the system. In Scandinavia, you are only in later, gestation week 10, 11, 12. So this is an underestimation of the prevalence of incidence of spontaneous abortions. Stillbirth, 0.3, 0.6, and a low rate on congenital anomalies here in the interferon beta exposed ones, only 13, 3.3. This is something which is going to be expected. Then data from the Italian registry. You saw already the relapse data. Here, women with natalizumab. Here, a couple of years published interferon beta exposed pregnancies, and here a larger group of not exposed pregnancies. And here you see a spontaneous abortion 6.2%, live birth 92. And Dr. Amato already mentioned the risk for spontaneous abortions was higher in the natalizumab exposed group, but I most likely think it's reporting bias. And if you controlled for the, I'm not totally sure how it works in the Italian system, but if you controlled for the number of doctor-physician contacts between the patient and the physician, then you would end up with similar rates of spontaneous abortions. Because, for example, in Germany, somebody who is fine on his interferon or nothing would go every 3 months to a doctor, and whereas natalizumab, women would go every 4 weeks, and therefore there might be a detection bias. These are data from our own registry, and what you see here, spontaneous abortions are also low. So my registry is a prospective cohort study, and women email us, call us, and we are just too late to capture all the spontaneous abortions, because some of them even intentionally only contact us because they want to have a real pregnancy and wait until the pregnancy is confirmed. So you see, it's not easy to define normal, and then you have to you still have to consider if you can compare this with just population-based data from other sources, and this is not easy neither, because perhaps easiest for the huge Scandinavian databases. And sometimes it's compare apple with pears, and might introduce some problems. In summary, I think pregnancy outcomes of untreated women with multiple sclerosis are very similar to pregnancy outcomes of healthy women. There is a little bit of a discussion if they deliver more likely via assisted delivery or cesarean section, and if the birth weight might be reduced about 100 to 150 grams. So now we face the problem that, it's not a problem, this is why we have this meeting, this is why ECTRIMS became a huge meeting, so we got all these drugs in multiple sclerosis, and it takes about 30 years to determine the reproductive toxicity of a drug. And a good example are the interferons, which are on the market about 30 years. A little bit the problem with the interferons was that there was no pregnancy registry. This has changed. FDA and EMA now require pregnancy registries with new drugs, at least if there's somehow the chance to get to be able to collect some pregnancies. And we just got the label update in Europe last fall. And EMA and FDA try to be a little bit more practical in their patient leaflets. So it's not only, they try to include human data out of the registry. So, and I think it's good also to include sample sizes of data being collected to allow physicians and patients to make an informed as possible decision in this. Like it's an orphan disease, pregnancy it's like an orphan disease because we do not have enough data. And based on this, the contraindication to restart the drug during pregnancy is out. The requirement of contraception is out, and in is the approval as the first drug we have in multiple sclerosis to be given during breastfeeding. And, oops, and you saw this slide before. This is the reason why it takes so long to answer these important questions. And if you have rarer outcomes, and one example is stillbirth, if we assume there is a 0.5% risk for stillbirths, then you need nearly 2,000 pregnancies to show this doubled. And we got more communications with the EMA last year to our MS drugs concerning pregnancy, and you already saw that. So they stated that the risk for major malformations was two times higher than the normal risk of 2 to 3%. again, what is normal? The EMA only considered the registry data, and Novartis has 3 data sources where data are collected. The red one is the registry. This PRIM is a little bit like a registry, and the blue one is the Novartis safety database. First of all, the EMA did not like at all the sample size of the exposed pregnancies, also in the Novartis pregnancy database. They said, okay, this is much too many. There are like 1,000 exposed pregnancies. This is also one reason for the contraindication, but for the major malformations, they only considered the registry. And this is true that 6%, this is quite on the higher side. I think there is, I personally think there is an intrinsic bias in these registries. This is more a methodological, epidemiological question. If you call them every 3 months, and there might be a selection who enters these registries, and then there might be also they are very regularly followed up, and there are, for example, data. If you follow up children by specifically trained pediatricians postpartum, your major malformation rates can go up also to 6%. This is what we do in the region of Mainz in Germany. So what does it mean for our patients? So I personally, I'm not sure if Gilenya is teratogenic or not. It's potentially teratogenic, and as Dr. Amato told you, has other problems. Namely, if you withdraw it, there are sometimes very severe relapses, and it's not the perfect drug to plan a pregnancy. We have, so really the drugs with the largest body of evidence are our injectables, and it's fine to keep them until a pregnancy test is confirmed, and most likely also beyond. But one other very important point, all the data you see being presented is exposure during the first trimester, and women are recognizing that they are pregnant, and most of them do it between gestational week 4 and 6, and then they stop the drug. We only have very few, and the largest number of exposure during the entire pregnancy was presented a couple of years ago at the meetings for Copaxone. But other than that, even in these huge amounts of first trimester exposure, only very few really continue during the entire pregnancy. I talked already about Gilenya, so the recommendation is to stop it 2 months prior to conception. And teriflunomide, this year there were a couple of, last year, pregnancies published, and so far, although it was very teratogenic, in the lowest dose there was no minimal dose under which there was no teratogenicity in animal studies. This was not shown in humans yet. And for me, here with DMF, perhaps, I do not disadvise to stop DMF before pregnancy. I tell women that they can stay on Tecfidera until the pregnancy testing is positive if they feel all right that we only have 300 pregnancies. So basically what I tell them, it's not my baby. I do not take this baby home. They take the baby home. There is a natural risk of 3-4% of major malformations, and then they should decide what they do. I think, and we have newer data also presented last year at the AAN meeting by Dr. Langer-Gold from the Kaiser Permanente system, but there were also data published last year from Austria and some data from MS-BASE showing that there might be in the mild to moderate MS no postpartum rebound. This is not true for women with highly active MS, and there might be especially in danger if we withdraw short-lasting and acting efficient drugs as natalizumab and, as I mentioned before, Gilenya. So natalizumab, I think the Italian data Dr. Amato mentioned are important. If there is a risk, if there was a risk of increased major malformations, this would be a problem. But normally it doesn't make sense because natalizumab has a very long half-life time. If you give it a relatively long half-life time, if you give it if you are exposed at the first trimester, and most of the organs are finished after the first trimester. So I think we need more data here. I think alemtuzumab was also can be an interesting option. I think CD20 antibodies are a very interesting option for women with highly active MS. Unfortunately, we have a very conservative label in Europe with 12 months after the last infusion. I actively disadvise my patient to wait a year. And I really advise them with the caveat that we have fewer than 150 pregnancies to become pregnant earlier. There will be, it's not published yet, but I'm the co-author of one paper. I reviewed the other one, and it will be published, and I will write the third one in the next few weeks, hopefully, and there will be really compelling results that these women, despite being highly active, will have no relapses during pregnancy and only very few relapses postpartum. This is mainly for rituximab because it's data from Sweden and Southern California. In our publication, there will also be some with ocrelizumab included, but it's a good result. But still, we see some relapses postpartum, as we see relapses in our alemtuzumab pregnancies. And if we stop to see relapses with some introduction treatment, then this means postpartum, then this means we can cure MS. So it's about 10, something in really highly active patients, perhaps 10 to 15% will have relapses postpartum, and this is also true for the alemtuzumab cohort. Cladribine, there are very few exposed pregnancies. And exposed means here women who became pregnant during the 6 months after the last tablet. And most of them electively terminated the pregnancy. And I think this is very interesting. So from the studies, there are 3 healthy newborns and post-approval. And we submitted this abstract for AAN. There are 6 cases reported. We have 4 in Germany, and they are really exposed, not at the end of month 5. They became pregnant really like during the intake of cladribine. And I was quite not happy. But so far, 3 babies are born, and the other one is just like perhaps gestation week 10. There's just a normal, as to expect at gestation week 10, pregnancy so far. So interestingly, we do not have one baby exposed to cladribine so far, which has a malformation, which does, of course, not mean to tell the women to become pregnant during the 6 months. And to my experience, if women ask you for a treatment recommendation and really planning a pregnancy, these are not the women who become pregnant. These women were all women who told their neurologist, I'm done, I have already 5 children, I do not need another one, or I don't know what, but it's a different population. And this is also interesting. The more toxic a drug is, the more different are the women who perhaps become pregnant under these drugs. So for example, it's totally true. So you really deal with other confounders. For leflunomide, for example, there were data for leflunomide that the birth weight might be reduced in leflunomide-exposed pregnancies. But if they corrected for smoking and education, it was a confounder, because much more women were smoking in this group. And I would like to summarize the pregnancy, the perhaps potentially abnormal pregnancy outcomes in correlation to the drugs in this table. I think for spontaneous abortion, this is really, really a challenge to capture them. But that's true for not only for MS, for any drug. Most likely, there is no risk for the current MS medications, and it's also very dependent on how you measure spontaneous abortions. Major malformations, perhaps fingolimod, steroids. There is a weak association with clefts. So careful to give them between gestation week 8 and 11. Potentially, there might be a risk for cladribine and teriflunomide, but so we do not know that. Stillbirth. So you might ask why I put CD20 here. I'm not sure. So the Roche presented data on their ocrelizumab-exposed pregnancies at the ECTRIMS meeting, and they had one stillbirth in 100 pregnancies. Then the Swedish presented their rituximab data. They also had one stillbirth, and I came to the idea to look at these data because at the ECTRIMS workshop, I was asked by another colleague from the US who had just recently a stillbirth in a CD20-exposed pregnancy to look a little bit more closely. So it might be a chance finding. We had that, for example, with cancer in the association with Mavenclad in the clinical trials, because if you have rare events, it's really important to collect a lot of data. Preterm birth, if you continue drugs during pregnancy, we see this if you give CD20 during pregnancy, but this also means, and this is not only MS, this is also other neuroimmunological diseases, mostly this means the disease is active. And we also see that the birth weight was reduced, and this also can be reduced with steroids during pregnancy. And we so far have no data on child development. And so my personal advice so if you ask me, I talked to 10 or 15 women with really severe rebound. And you can imagine you have women who, my last one, she was on December 31st with her older kids at her trampoline in the garden. We had a especially mild December. And on January 2nd, she was admitted in a university and at the ICU of at the hospital of the university hospital in northern Germany and transferred to the ICU 5 days later because she was tetraplegic. And she stopped natalizumab. So she had an EDSS of 9.5. And they put her on the ICU because she had a brainstem and cervical cord lesion. She could not even press the spell to call somebody. So this is really, this rebound is worse than PML, I would say, because with PML, at least you have a likelihood of having an EDSS lower than 9.5 or 8. These are the women we really have to take care of. And I think CD20 antibodies or alemtuzumab and in medium active cladribine might be a good option. There will be some questions how to perhaps what is the switch relapse risk in patient, for example, being on Gilenya? This is also not easy. I also saw severe rebounds trying to switch these patients. And those on natalizumab keep them on the drug. And we will get more data, hopefully, in the future. And this is a summary. A lot of it has already been said, and I think really everybody can contribute by by putting the exposed pregnancies into registries if you have registries in the country. So I will talk a little bit, not much, on breastfeeding, and that's first of all, breastfeeding is healthy. And it's not to put pressure on the women, so it's totally proven that it's a healthy thing to do so. It's recommended by the World Health Organization, but it's very emotional. To my personal opinion, and being mother of 2 children, which I had breastfed, it's very unlikely if a woman does not want to breastfeed that you bring her to make her able to breastfeed exclusively. So if you have somebody who tells you, I do not want to breastfeed, it's not worth I think, to open the discussion for us, at least as neurologists, and to convince her. But women who want to breastfeed, I think we should support to do so, perhaps even in combination with the medication. And there are some data, there will be new data, hopefully soon, showing that breastfeeding is not harmful. So we know that. But this might not be true. So in the natalizumab women, there are also some who have really bad relapses postpartum. Large molecules are unlikely to enter the breast milk. And the interferons are approved now during breastfeeding. Copaxone is not approved in Europe during breastfeeding, not even with a risk-benefit consideration. So I think this is doable. I would extend the recommendation to perhaps think of breastfeeding under treatment to all monoclonal antibodies we have in multiple sclerosis. There are no measurements for ocrelizumab, but it will be very low, and there are neonatal Fc receptors in the intestine of the child, but in contrast to certain animal species as sheep or mice, the absorption of antibodies during the intestine is zero, nearly zero, to a biological active level is in humans 0, and I think in a couple of years, if we have chronic diseased patients, they will breastfeed, and the EMA already changed the wording here for the migraine CGRPs that breastfeeding is okay after risk-benefit during the treatment. And there was a new publication from San Francisco at the end of the last year, who measured rituximab in the breast milk with a very low relative infant dose, 0.04. We have some measurements of natalizumab. We have a baby whose mom was treated during pregnancy. We can measure natalizumab in the cord blood of the baby at birth. And while the baby was breastfed, the natalizumab, under natalizumab treatment of the mother, the natalizumab levels go down to not being measurable anymore. Even in rheumatology or other fields, everybody tells you have to be careful in preterms. So I think because the idea is that the endothelium is looser and that large molecules could pass. So this is something which is not clear so far. I have one woman who delivered quite preterm in gestation week 28, and the neonatologist supported her to breastfeed under rituximab, and she did so. Very interesting, this case, and this will also be something we have to follow and focus during the next years. If we have under CD20 and long-term CD20 treatment, low immunoglobulins in the mother, immunoglobulins are as antibodies are transported from the mom to the baby. So this will be a question if the babies are at higher risk for infections. Because our rituximab baby had also very low rituximab levels, immunoglobulin levels at birth, and got a special vaccination, a passive vaccination with antibodies. To conclude here at this part, that if they want to, and that's the important thing, that we should encourage them, we need more data under medication, perhaps even under our orals. So, for example, cladribine is a lipophilic drug, and we try to measure it in the milk. And after the 3rd day, we only have a relative infant dose of 3%, and we also try to measure DMF. And the relative infant dose would be very, very, very small, of 0.002%. So, but these are only one sample each, and I think we have to collect more data. And I think we as physicians have an important role to be vigilant. Teratogenicity, there was one study who tried to tangle which system is best to discover teratogenicity, and sometimes physicians are better than the collecting system of the FDA. And this year's Professor Jans, I had the pleasure to meet him at the epilepsy and pregnancy meeting, and he already described, this is German, but in 1964, that we urgently have to investigate the teratogenic potential or the effect of our anti-epileptic drugs on the outcome of pregnancy. And this, of course, epilepsy is something totally different. If you withdraw the drugs, they can have seizures. They can be life-threatening, and women with epilepsy are really at risk for any adverse pregnancy outcomes. But this is the achievement they have done. These are data from the Nordic Registry in the last 13 years. So they reduced the relative risk for major malformations by 27% with a stabilized prevalence of seizures during pregnancy. And of course, it's different, but I think we will be there in the next couple of years, that we, especially for our highly active patients, are able to combine our medications with having the most normal as possible pregnancy outcomes. Thank you.